So thanks for being here, Cliff. Of course, we have the largest ever audience from Australia for this episode, and it shows your superpowers in recruiting your fellow countrymen and women, and making sure they hear and see you. And like I mentioned in previous episodes, when someone like of Cliff's caliber teaches your dermoscopy and we equip you with a dermatoscope, we feel like we've given you superpowers. This is something really special, and I hope our products will make you empowered to do good things for your patients and deliver excellent care. So before we start, a little housekeeping in case you haven't seen a previous episode. If you'd like to ask a question during Cliff's talk, use that Q&A feature. It's a button at the bottom of your screen anytime. It's basically a formal way of asking questions, and we'll try to get to everyone's questions. It gets a little bit out of hand. These are large webinars, very popular. So we have hundreds and hundreds of people joining us. So I apologize ahead of time if we don't get to everyone's question. And one question that we get asked a lot is, can I watch this afterwards? And yes, an email will go out to you 24 hours after the conclusion of today's episode with a link to the recording. So there's no need to ask, you'll automatically get that. So in case you joined us late, or you have to leave early, or you want to watch a past episode, you'll get those links. Okay, Cliff, I think we're ready to start. If you want to share your screen now.
Thank you.
Excellent.
Slideshow. Okay, how's that?
We can see it. Perfect.
All good. So thank you very much. And yeah, the dermatoscopic jungle, hunting big game with confidence is what this is all about. And greetings from just offshore from Brisbane, Australia, here. And this is my own particular jungle where I live, off the coast of Brisbane. And it's a very pleasant place. This is my little rowboat over here and live up here, and this is a whale. This is one jungle book. This is the Disney Jungle Book. And this is another jungle book. This is Dermatoscopy and Skin Cancer, Handbook for Hunters of Skin Cancer and Melanoma. It's also a conflict of interest, because if you don't already have it, I recommend that you purchase it. There are two reasons why I chose a British publisher. One is that it was a very good publisher, and the other one was I knew Boris would keep the value of the pound suppressed by joining Brexit. So the price is good, and you can get it on Amazon or one of the other local providers. Now, this is the jungle where I hunt, and doing an effective skin examination is fundamental to successful hunting. And this link is to a 12-minute video showing you the way I do a skin check. Not the only way, but it's the way I do it, and it's quite detailed. So Thorsten will share this link with you. If you haven't already seen this video, then you can watch it. Now, the other important thing for successful hunting in this jungle that we work in is pattern recognition. And some people are experts at pattern recognition, and some people may not be so confident, but I want to see how good you are. So I'm going to show you two skin lesions now. I want you to see how long it takes you to determine which of the lesions is innocent and which is suspicious. So you're ready? Here we go. So they're both skin lesions, they're tattoos, and it took you no time at all to work out that the one on the right was very innocent and the one on the left was very suspicious, because pattern recognition is innate human behaviour. We all do it. Pattern analysis, on the other hand, is describing patterns in a reproducible and a teachable manner. And that's something which must be learned. Now, when you look at this collage, it doesn't take you any time at all to recognise a guinea pig, a koala, a dog, chimpanzee, and giraffe. Because we are programmed to recognise symmetrical faces. When you see someone you know, like your mother or an acquaintance, you recognise them instantly. You don't need an algorithm. This image on the bottom right, okay, you worked out it was a tiger, but it wasn't the same instant recognition. You had to stop and think about it a little bit because it's asymmetrical. Our brains are programmed to recognise symmetrical faces. And this book by Daniel Kahneman, Thinking Fast and Slow, talks about two types of thinking. And pattern recognition, or recognising a person's face, is type 1 thinking. It requires no effort. It's like recognising your mother's face. Now, there are 5 common benign groups of lesions, and these cover 99.9% of what you will see at work every day. Nevus, non-keratocytic, which is SEBK, sol lentigo, sebaceous gland hyperplasia, hemangioma, and dermatofibroma. You will see these on every patient, almost. And you can learn to recognise these by pattern recognition like you recognise faces, but you need to learn it. And we learn it by seeing many, many different varieties of these 5 groups. Because there are many types of nevi. There are many, many different appearing seborrheic keratoses. And it's only by looking at lots and lots of them that you'll become an expert. But it's easy to become an expert recognising the common benign things because they are so common. And what you have to do is apply your dermatoscope to numerous examples every day deliberately. Don't just put your dermatoscope on things that you don't recognise. Put it on things that you do recognise so you become an expert at recognising all the different varieties. Because when you can instantly recognise what is benign, you will also instantly know when to be concerned. Now, the first 5 are easy, but this one is not symmetrical. Now, you may recognise that by pattern recognition as a melanoma. And with time, most things you look at, you will recognise by pattern recognition. But at the early stages of learning, you may find this lesion confusing. And that's when an algorithmic method is useful. Now, dermoscopic algorithms, there have been many published, but they are all based fundamentally on the feature of symmetry. Benign lesions tend to be symmetrical because natural forces favour symmetry, whereas malignant lesions tend to be disorganised and asymmetrical. And all algorithms are based on this principle. So we have asymmetry, then we have various clues. And this is pattern analysis. Using an algorithm is type 2 thinking. It requires some effort. It actually burns up some calories. Now, these are 2 examples of algorithms. Chaos and clues for pigmented lesions, and prediction without pigment for non-pigmented lesions. And I'm not saying that these methods are better than other methods. What is in fact the truth is that if an expert uses chaos and clues, the outcome will be the same as if that same expert uses a 7-point checklist or a 3-point checklist, because it's the expertise of the person and the experience of the person that determines the accuracy of the method. What is different about these 2 methods is that they don't involve any calculations. They are easy to teach and they are easy to use in routine practice. And that's why these are the methods that I favour. So chaos and clues. We have a pigmented lesion. We look for chaos, which is asymmetry of pattern and or colour and or border abruptness. If we find chaos, we look for one of 9 clues, and if one of 9 clues is present, we proceed to an excisional biopsy. If the lesion is pigmented, and is not asymmetrical, not chaotic, before we discard it and move on, we consider whether we can actually make a diagnosis of one of the 5 common benign things. And if we can't, for whatever reason, we look for exceptions. Now, the clues for chaotic lesions are grey and blue structures, an eccentric structureless area, thick lines, reticular or branched, black dots or clods peripheral, lines radial or pseudopod segmental, lines white, lines parallel on the ridges for palms and soles, polymorphous vessels, and polygons or angulated lines. The exceptions are, and this is where we consider lesions which are symmetrical, but we can't confidently call them a benign diagnosis, any changing lesion on an adult, a nodular lesion with any of the 9 clues, or a small lesion less than 6 millimeters diameter with any of the 9 clues, any lesion on the head or neck with pigmented circles or dermatoscopic grey, and any lesion on the palms and soles with a parallel ridge pattern. Very small, or nodular melanomas or early melanomas on the face and the palms and the soles may be symmetrical. And that's why the exceptions are there. Then we have prediction without pigment. This is very simple. You have a non-pigmented lesion, none of the colours of black, brown, grey or blue, none of the colours of melanin. First of all, if we can't give it the diagnosis of one of those 5 common benign things, we look for ulceration. If ulceration is present, we proceed to an excisional biopsy. The most likely outcome will be basal cell carcinoma. If there's no ulceration, we look for white clues. We don't look at the vessels, we look for white clues. And the white clues are in any lesion, white lines, or in any raised lesion, keratin scale, white circles, or white structureless areas. So if there are white clues, we do an excisional biopsy, we don't look at the vessels. We only proceed to the vessels if there's no ulceration and there are no white clues. So vessel pattern analysis is easy. If there is a non-benign vessel pattern, we cut it out. Now the benign vessel patterns are clods only, centered, serpiginous, and reticular. Clods only hemangioma, centered, seborrheic keratosis, or a nevus, a congenital nevus, serpiginous, clear cell acanthoma, and reticular is sun-damaged skin. These are benign. So if it's a lesion of concern and it hasn't got ulceration, hasn't got white clues, and it has a pattern other than these 4, we cut it out. So now we get to the real jungle. These are situations which even challenge algorithmic methods. And the main one of these is the patient with hundreds of lesions. And these can be very, very challenging. And the suggestions I have here, firstly, are examine as many as you can dermatoscopically. That may mean scheduling extra time for people with multiple lesions. My second suggestion is to examine with your dermatoscope in your hand, not a magnifying glass, not a head magnifying system, but with your dermatoscope in your hand so you can immediately look at multiple lesions. Use your dermatoscope as a light source and then look through it frequently. And with these patients with multiple moles, I've found that the most reliable early sign of a melanoma is chaos of border abruptness. Now, nevi are expected to have a uniformly gradual border. Seborrheic keratoses and solar lentigenes are expected to have a uniformly sharp border or abrupt border. When you have a lesion which has chaos of border abruptness, some parts of the border abrupt and some parts gradual, that may be the first clue to a lesion which is not benign. Now, in the example here, in this collage, we see we have a chaotic lesion. We have a very abrupt border here and a very gradual border over the rest of the lesion. And the reason is that this is a melanoma arising in a congenital type nevus. The nevus has the gradual border expected of the nevus, and the melanoma has a variable border, including some parts which are abrupt. This is a very, very useful clue, especially on the patients with hundreds of lesions. Gradual border, abrupt border. Chaos being defined as asymmetry of all of pattern, colour and border abruptness. This lesion has asymmetry of all three. You only need one to diagnose chaos. Melanoma invasive. Here are the clues. Eccentric structureless area out here. Black dots or clods peripheral along here. And white lines in the centre of this part here. Chaos and clues, melanoma invasive. Here we have two types of patients with multiple lesions. On the left, you have a lady with multiple nevi. And you know that if a patient has more than 100 nevi, the relative risk for melanoma is 7. It's a high risk. And that's not because the nevi are at risk. It's the nevi being, the multiple nevi are a marker for melanoma risk. They are not at an increased risk themselves. This patient with multiple nevi has a 7 times higher risk of melanoma, but 3/4 of her melanomas will come de novo, not associated with the nevus. This patient on the right is a typical Australian, and his multiple lesions are not nevi. They're seborrheic keratoses and solar lentigines. So let's look at these two patients, and you can look at them now and see if you can work out where the melanomas are. They both have one melanoma, and I know they only have one because this was about 10 years ago and they haven't had any since. Here's the lady, and here's her melanoma. It's just like one of the other spots. And here's the dermatoscopy. And you can see here that if you're looking at the colours, it's not that asymmetrical. If you're looking at the patterns, it's not that asymmetrical, but it does have an abrupt border here, a very abrupt border here, and a very gradual border here. So it's got chaos of border abruptness. And this was the clue in this particular case. Now, clues, well, I had to look hard, and eccentric structureless area, because this does extend the edge here, but not here. And so, and this was a melanoma in situ. Now the gentleman, this was his lesion up here, this little tiny speck. It's one of the smaller ones on his body. You can see the lesion is asymmetrical, and it includes chaos of border abruptness with an abrupt border here and a gradual border up here. But it actually has chaos of all three, pattern, colour and border abruptness. And clues, well, it's got grey and blue structures here, and an eccentric structureless area out here. Now, I'm going to show you the patient's, an example of a patient with multiple nevi, or two patients actually, with multiple nevi, and a melanoma. And we're going to look at multiple lesions under the dermatoscope and see which ones we need to consider. And this is back without the stickers on it, and this is the back with the stickers on it of the lesions I'm going to look at. You'll notice it includes buttock nevi. Now, this is interesting because that's one of the features originally listed in the original paper on dysplastic nevus syndrome by Elder. As the patients, these patients had buttock nevi. But these are not acquired Clark nevi. These are congenital type nevi. Notice how they're not on sun-exposed or sun-damaged areas. They're on covered areas of skin, including the buttocks. So this thing called so-called dysplastic nevus syndrome is actually the nevi in these patients are congenital type nevi. They're not Clark sun-acquired nevi at all. Now, this is another young lady with multiple nevi, and I'm going to give you a collage of nevi from both of them. You won't know which is which, because one of these young ladies has a melanoma, one doesn't. So here's the first 9, and I think we have a poll here, I think. That's correct. And Thorsten will explain to you what we're going to do. Okay, so of these nevi, I'm going to select 4 that need consideration. And number 1, I've selected because some of you may be concerned that there's some asymmetric grey here. But notice it has a gradual border over the total perimeter, right? And there's no real asymmetry apart from maybe the grey's a little bit more this side than this side. Number 2 has a, now is that poll obstructing everyone's view of the lesions at this stage, Thorsten?
Obstructing?
Would it be better to, can you just withdraw it for a little bit and then put it back?
Afterwards, if you want, yeah. I just wanted to show
Yeah, because I'll go through the lesions first and then we'll put the poll back on the last slide. So number 1, number 2, 1 pattern lines reticular, 1 colour brown, and a gradual border over the total perimeter. That's a pattern recognition nevus, no question. Now, if you struggle with that with some of these, this is what comes by looking deliberately at lots and lots and lots of lesions, because you're not going to find every one of these lesions to be malignant, so you have to have a way of distinguishing and picking up the ones you're concerned about. Number 2 is a pattern recognition nevus. Number 3 is a pattern recognition nevus. 1 pattern lines reticular, 1 colour brown, gradual border. Number 4 is a pattern recognition nevus. 1 pattern in the centre, structuralist, 1 pattern around the outside lines, a gradual border. Number 5 is a pattern recognition nevus. No suspicion at all, 1 pattern, symmetrical. Number 6, notice how these congenital type nevi have a very, many of them have a concentric pattern. So you've got a pattern in the centre, a pattern around that, and a third pattern around that. This is very, very common in congenital nevi. Another pattern recognition nevus. It doesn't matter, it's a little bit different at this end. That's consistent with biologic symmetry, as is number 8. Now, number 9 is different. We have 2 patterns asymmetrically combined, so we're going to put this one aside and consider it at the end. So number 1 we're putting aside, number 9. Now, number 10, pattern recognition nevus. Same with 11, same with 12. 13, okay? This is a problem. We've got to look at this one at the end because it hasn't got a uniformly gradual border. Some parts are abrupt, like up here. And although it's symmetrical in most other ways, the border abruptness is asymmetrical. This one's a problem. Number 14 is a pattern recognition nevus, as is 15, as is 16, as is 17, as is 18. 19, the grey is not a clue because the lesion is symmetrical. 20 is symmetrical. This one looks a bit different. It's a different pattern to all the others. This has got a clod pattern. So we'll put this one aside for further consideration. 22 is a pattern recognition nevus, as is 23 and 24 and 25 and 26. So these are the 4 lesions we've selected as being of concern. And this is where you do the poll to pick which one you think is the melanoma. Only one is.
Here it is.
And you can tell me, Thorsten, when to proceed.
We'll let the majority vote. So
yep,
vote now. Okay, 3 more seconds. 3, 2, 1. That's it. All right, here it is, Cliff.
Right, we have a nice variety, and the majority go for 13, and that is correct. Okay, Do I close that? That's right. Okay. So here's number 13, right? Now, first of all, number 1. Okay, although there's a little bit of grey there, the lesion basically has one pattern structureless, a gradual border over the total perimeter, and a little bit of grey, which is a bit more to one side. That's biologically okay. I didn't cut that one out. This was 10 years, many years ago. Number 9, okay, it's chaotic, and it's got a clue of the eccentric structureless area. If you cut this one out, that's okay. Patient won't die from that procedure, okay? And we always cut some benign things out, including the malignant things. And that's called the benign to malignant ratio. And if you're a beginner, it might be 15 benign to 1 malignant. If you're an expert, it might be 3. 2 benign to 1 malignant. But it's okay to cut things out, and you'll cut less benign things out when you get more experienced. When you look at this pattern here is reticular. This pattern here is structureless, and it's a gradual border between the two. There's no great degree of internal disorganisation in this lesion. I didn't cut it out. For me, it's a pattern recognition nevus, but don't feel bad if you decided to cut it out. This one over here, number 21, I didn't cut it out. This is a pretty typical congenital type nevus, clod pattern or cobblestone nevus. If you cut it out, won't kill the patient. It's okay, but you'll soon stop cutting them out, because when you've looked lots and lots of nevi deliberately, you'll see this sort of pattern quite often. Now this one here, number 13, is quite different. So you can see for a small lesion, it's got a pattern of clods. Now some people call this inverse network. It's just clods separated by hypopigmented tissue. It's got a reticular pattern around here. It's got a structureless pattern. But importantly, parts of the border are abrupt and parts are gradual. And that's what gives this asymmetry. Because it hasn't got asymmetry of pattern, but it hasn't got asymmetry of colour. You don't look at little tiny variations of colour like this when you're assessing symmetry, right? What you do look for very closely is once you've assessed it as having chaos of border abruptness and therefore chaos, look for clues. There they are, radial lines, all down one side. Chaos and clues. It's a nice, simple system. No calculations. And an algorithm is really something for you to use as a scaffolding on which to store your accumulated experience. Because when you've been doing this for a couple of years, you'll look at that and you'll say melanoma. You won't need to put it through the algorithm. It'll be pattern recognition. Okay. Now, another thing with these patients with hundreds of lesions is to look for the dermatoscopic uniqueness or the dermatoscopic ugly duckling sign. The lesion would look dermatoscopically different to everything else on the patient.
Cliff, one question we have, you said changing lesion in adults as an exemption. Does it apply to any pigmented lesion? And what age would you consider as an adult here?
Okay, so it's a very good question. And we're going to cover that one in a minute, because if you're under 20, you're not an adult. If you're over 50, you are an adult. And in between, well, you have to use judgment. And I'll show you how to do that in one of the cases coming up. If you have a changing lesion over 50, it's almost certainly going to be malignant, or unless it's a seborrheic keratosis or one of the 5 common benign things. But if you think it's a nevus, then it won't be a nevus if it's changing. If it's under 20, it will be. 999 times out of 1,000, it will be under 20. If it's changing, it'll be a nevus. In between 20 and 50, you have to exercise judgment, and I'll show you how to do that. Good question. Move on. Okay, so here we have a lady, and we have a number of spots. And one of these is going to be a melanoma, and I guarantee that you can't pick it. Well, you might guess, but it'll only be a guess. You can't see anything there that you would have thought was a melanoma until I told you there was one there, right? So I'm going to show you some lesions from her abdomen, all in that field, and show you how easy it is to pick the one which is the dermatoscopic ugly duckling, or one which is unique compared to the others. Okay, now, because I told you there was one, it wouldn't be hard to pick this one here because it's obviously different to everything else. Then look at the other ones. Here we have a gradual border over the total perimeter. We have one pattern structureless. The colour's a bit to more than one side, but this is biologically symmetrical. Another one biologically symmetrical. Another one biologically symmetrical. Symmetrical. They're all different. Symmetrical, 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 symmetrical. Right? And you'll get to recognise these as pattern recognition nevi with practice. Symmetrical. Now this one's not. It's got one pattern here and one pattern there. So it's chaotic with an eccentric structureless area. Well, I can tell you now that you don't get a straight line like that separating two patterns in a melanoma. This is something which comes with experience. This is one non-chaotic part here and one non-chaotic part here, separated by a straight line. This is a congenital niche. If you cut it out, it won't kill the patient, but the chaotic behaviour of malignant tissue creates disorganised patterns, not straight lines like that. That's why the word chaos is not just describing asymmetry, it's describing a particular behaviour of tissue. Malignant tissue doesn't follow any laws, and it certainly doesn't give you a straight line demarcating two land patterns. This little lesion here, this is different to everything else. This one's also symmetrical. This one's different to everything else. And we'll look at it. You think it's chaotic? Well, it is, because if you put a line through here, the line's reticular here, the structure's up here. So it's chaotic. It's not chaotic of border abruptness, only of pattern. Only of pattern. It's not chaotic by colour or border abruptness. It's chaotic by pattern, so it's chaotic. Clues, well, look very close to the clues. See these two radial lines? That's just artefact. The radial line there, the radial line there, and thick lines reticular, where the lines are thicker than the holes that they surround in here. And they're focally present because that's the way malignant tissue behaves. It causes small changes, focal changes, not large, broad changes over the whole lesion like in the seborrheic keratosis. Now, can you pick which one it is? So I'll show you. There's that little fella there. Okay? But if you hadn't put your DermLite on that, you wouldn't have made the diagnosis. You actually have to put your dermatoscope on each of those lesions there to find that one. If you only put it on the big ones, you haven't got a chance. Every melanoma starts smaller than you can see it. The big ones, they deserve attention because they may be melanomas that have been missed several times before. But the little ones are even more likely to be melanomas. Now, here we have a lady's thighs. I'm going to show you 4 lesions. And we have a pole here. So there are the 4. And we're talking about dermatoscopic ugly ducklings. And you are asked to pick from 1, 2, 3, or 4 which one you think is the melanoma.
All right, 3, 2, 1, vote now. Okay, here it is. You see it?
Well, that's interesting. That's fascinating. Okay, let's have a look at these 4 lesions. Most people pick one. Okay, it's got one pattern in the centre, another pattern around the outside. Okay, it's a bit darker on this side than this side. Yes, I can see that people would be concerned about that. But this is the one that's different to all the others. This is the only clod pattern lesion. These are all mixtures of lines reticular and structureless. This is clod pattern. You're looking for the ugly duckling, the dermatoscopic ugly duckling, the one that breaks the pattern of the signature nevi on this patient. So let's look at this one. Is it chaotic? Is it chaotic? No, it's not. That's symmetrical. That's about as symmetrical as you can get. It might look internally disorganized, but it's symmetrical. So when you have a symmetrical lesion, you've got to decide it's a lesion of concern. And it's a lesion of concern if you can't diagnose it as a nevus by pattern recognition. Now, I'm going to worry about said case, sebaceous hyperplasia, hemangioma, dermatofibroma. It's just, is it a nevus? I couldn't confidently call that a nevus because it wasn't like a nevus that I'm used to looking at. I'm not used to looking at nevi that have a pattern of clods of varying colour, including grey. Okay, this is not what you expect a nevus to look like. You might have a cobblestone pattern congenital nevus with all brown clods, but you won't get a nevus with clods varying in size and shape and colour, including grey. So it was a lesion of concern. So that means I can look for exceptions. And the exception here was that this is a small lesion with a clue of grey. Okay, this is how the exceptions work. You don't apply exceptions to every lesion, only if you can't confidently call it a nevus. Now, going back, if you were concerned about this one for the same reason, small lesion with a clue, yeah, cut it out. Doesn't matter, right? It doesn't matter. What you can't do is cut them all out, right? You can't draw the line somewhere. And so if you find, looking around, a lot of ones look like these, but nothing else looks like that, you'll cut that one out. But don't feel bad if you pick that one, because it's quite okay to cut benign things out as well as malignant things. As long as you cut them out for a plausible reason that you have worked out and you can justify it, cut it out. Great case. Do you pick which one that is?
Someone
that
picked
one
a skull in it.
Yep. So it makes it pretty easy when it's in the middle of the picture, but that's the one it is. Now, minute but dangerous lesions. So I call this diligent diagnostics. There are lesions you will not diagnose unless you apply your dermatoscope. This lady's 61. She had a skin examination. As you always do, you've retracted the bra strap and you've found this little 3 millimetre lesion under the underwear that she is not aware of. So you put your dermatoscope on it. Chaos or no chaos? Symmetrical or asymmetrical? Well, that's symmetrical. It's got structures in the centre. It's got clods around the outside. It is symmetrical. It looks disorganised, and that's a concern, but it's symmetrical. So you've got to ask yourself, can you call that a pattern recognition nevus or seborrheic keratosis? I couldn't. That's not what a nevus looks like. And apart from abrupt border, it has no other features of seborrheic keratosis. So I couldn't call it either, so I could look for exceptions. In this case, the exceptions are that it's a changing lesion on an adult, and it's a nodular and a small lesion with lots of grey. I cut out nodular melanoma, Breslow, 0.9, nearly a millimetre. This is the thing. Radial lines, pseudopods, and peripheral clods are all dermatoscopic clues to a changing, growing lesion. And this lady at 61, that's not acceptable. Okay? This is a great case because it shows you that you don't need to know about a lesion's history to say it's changing. If it's got peripheral clods, pseudopods, or radial lines, it's changing. Now, I don't care whether you call these structures pseudopods, peripheral clods, or radial lines. It doesn't matter. They all mean the same thing. They are circumferential. So they're not a clue because they're all the way around, but they are a clue to growth. They're not a clue as in chaos and clues, the 9 clues, because that must be segmental. But they are there and they are a clue to growth. This is a changing lesion and it was a nodular melanoma. Now I want to show you this nodular melanoma compared to a growing nevus on an adolescent. They both have a structural centre and peripheral clods, but the growing nevus is not a chaotic lesion. The melanoma is a very disorganised lesion internally. That's because what you're seeing here on the right is consistent with the chaotic behaviour of malignant tissue, whereas what you're seeing on the left is just a growing lesion without the chaotic behaviour of malignant tissue. Excuse me. Now, the question before about when is a patient, how is mature age defined as far as a changing lesion? This is an example to show that. This patient is 35 years old. He's not under 20, he's not over 50. And this lesion has peripheral clots. And it's not chaotic. So can you recognise the nevus by pattern recognition? Well, because he's 35, you're going to have some doubt because it's growing, and at 35 it might be, but it gets in there. It's also got some grey in it, and you know this is not. It needs some clarification. This is where we need to use some sort of a system to put this in perspective. What we do is we compare this to the other lesions on the same patient. Now, this is something artificial intelligence can't do. This is an example where artificial intelligence can't give you the answer. It's a changing lesion on an adult, we know that, and it's a nodular, it's not nodular, it's a small lesion with a clue and grey colour. So it qualifies on exceptions if it's dependent on the age, right? So let's see if what the other lesions of this patient look like. Okay, number one, and that one. This was the only one on this patient with peripheral clods, so we cut it out. It was a melanoma in situ. If we found 4 or 5 others, we may not have cut it out. But this is where you use context to decide at intermediate age whether it's significant. Now, another example of diligent diagnostics. This is a lady she's 37 years old. She's got a red spot in the middle of her left thigh and a red spot in the middle of her right thigh. I'm going to show you the close-up. This is the spot on the left thigh. This is the spot on the right thigh. Now, they're non-pigmented. Here's the dermatoscopy. So we'll look at the one on the left thigh first. We're putting it through prediction without pigment. And this is a really simple method, very effective. It's non-pigmented, so we look for ulceration. There's no ulceration. Secondly, we look for white clues. There's no white clues. So now we look at the vessel pattern. These are the 4 benign vessel patterns, and this is a clods-only pattern. This is a benign pattern, hemangioma. Now, notice there are some linear variants at the edge. When you look at thousands of hemangiomas on Monday morning, when you get back to work, you'll see that very small hemangiomas often have linear variants at the edge. This is still a clods-only pattern, and that lesion is still on that lady's left thigh. Have a look at the lesion on the right thigh. It's non-pigmented, there's no black, brown, grey or blue. So look for ulceration. There's no evidence of ulceration. Look for white clues. And there they are, white lines. Ignore the 4-dot clog of the rosette. That's not a clue, not one of our white clues, right? Because it's often seen on normal skin, on some damaged skin. These white lines, these Polynesian-Pacific white lines, they are clues. We cut it out. We don't even look at the vessels. It's got white lines. That's enough. Nodular melanoma, Breslow thickness 0.8. With the Breslow thickness less than a millimetre, 97% 20-year survival. Very important to make this diagnosis at this time in this 37-year-old lady with 3 little kids. Very important diagnosis to make. And I do highly recommend that you purchase this book if you haven't already got it, because this is straight out of the book. And this is an example of the quality of the images in this book. Oksana sorted through 100,000 photographs to choose the images for this book. My co-author, Oksana Marazava. Very high quality and very useful cases. Now, minute but dangerous lesions, very important to listen to your patients. Listen to your patients. Don't ignore when they have a concern. This young lady, who's also 37, pointed this out to me. This minute lesion, about 2 millimetres in diameter. She told me it was new. And when I looked at the dermatoscopy, this was a bland lesion. It had a gradual border. It was structureless. No clues there for me. Maybe some of you would have cut it out. I didn't cut it out. I monitored it for 6 months. Look what happened. Nearly tripled in size and developed white lines. Chaos and clues. Cut it out, and it was a invasive melanoma, Breslow thickness of 0.3 millimetre. That's scary. Already invasive. And so bland 6 months before. I'm really glad I didn't ignore the patient and that I monitored it over 6 months. Very, very strong lesson there to learn. Now, what do you, another, yep.
Cliff, we have 2 questions. One is, what's the difference between a clot and a globule? And then we have one regarding vessels on the periphery, whether they're a clue too.
A clot is the same as a globule. Globule is the metaphoric terminology. Clot is the descriptive terminology. Now, other question?
Sorry, I have a bad connection myself. The second question is the vessels on the periphery, whether they are a clue also.
Vessels at the periphery? No. You were talking about these vessels here. No, that's not a clue. I'm just saying this is a clods-only pattern, even though it's got a linear vessel, because the linear vessel is at the periphery. So that's just something that is still a clods-only pattern, but that's not a particular clue. Did you have a question too, Thorsten?
Let me see, I'm just reading it. When we see vessels on clods, it's a clue to melanoma. Should be over the surface of the clod or around.
Yeah, when you see a vessel within a clod, that's a clue to melanoma. Vessel within a clod. Yeah, that's true.
Okay.
Move on?
Yes.
Okay. So, swarm intelligence. I highly recommend that you consider the advantages of swarm intelligence. Now, Christopher Renner wrote a paper on this, and this is a paper based on the artificial intelligence studies, where it was looked at the efficacy of using the grouped decisions of multiple people. And it was found that 4 novices were better than 1 novice, and 8 novices had an accuracy approaching that of 1 expert. So if you pulled the decisions of 8 novices, the result was very, very high. And this can be used in a number of ways. Now, I examined my patients with a nurse, and the beauty of that is that the nurses are better than me. And so when you're examining someone with someone who's better than you learn. And also you find a lot more stuff than if you examine by yourself. Now, here's an example. This is a 70-year-old male, and believe me, 70 is not old, right? It's not. And I examined him, I didn't see anything, but my nurse said, look at this. And she was pointing to this little thing here. You put the dermatoscope on it. And I said, well, it's a melanoma. It's asymmetrical. It's got 3 little pseudopods or peripheral clods or radial lines, whatever you want to call them. It's a melanoma. And it was a melanoma, and it was invasive. 2 millimeters in diameter, invasive, Breslow 2.25, and I hadn't picked it, but she had. And I'm talking about Oksana Marazava, because she was my nurse at that time, and she's the co-author of this excellent book. And this is the quality of diagnostics that I was working with. And it's incredible when you work with someone like that, the things you find that you wouldn't find otherwise. And it works 2 ways, because you compete against each other. It makes work a lot more fun, and it's cost effective, because the additional things that you discover and treat more than pay for the wage of the person you're working for. And that's Oksana. Swarm intelligence, highly intelligent, and a great suggestion to work with a person. It actually is cost effective. Now, this is the other sort of swarm intelligence. Groups like the International Dermoscopy Society, 24,000 members, and many of you here today are members of that society. And this is NISA examining spots on a horse with the DermLite 100, DL100. And that's a very fortunate horse, because NISA is an expert. In fact, her teaching abilities are legendary. The cases she puts up on the Facebook site are incredible. And if you haven't ventured to that site, I highly recommend that you do it, because you'll learn so much. And this is another example of swarm intelligence, where you have hundreds of people commenting on cases that you put up. You can put up your own cases, you comment on their cases. It's a highly recommended activity. And finally, there's no substitute for examination with a dermatoscope. This is a 33-year-old male. I'm going to show you clinical and close-up images of 17 pigmented skin lesions. I'm going to tell you now that one of them is a melanoma. And I want you to see if you can pick it from the clinical and then from the dermatoscopy. So we have a poll here, but I'll go through all the cases before we put the poll up. You'll be asked to pick which one is the melanoma. And I'll get you to, as we go through, I want you to write down with a pen and paper or whatever way you can record it on it, just for your own benefit, which one of 1 to 17 you think is based on the clinical images. So here we go on the clinical, that's 1. If you've got a pen and paper, just write down 1 if you think that's a melanoma, and nothing if you think it's not. It's 2, 3, 4, 5, 6, 6, 7, 8, 9, 10, 'Clinical and close-up images of 17 pigmented skin lesions. I'm going to tell you now that one of them is a melanoma. And I want you to see if you can pick it from the clinical and then from the dermatoscopy. So we have a poll here, but I'll go through all the cases before we put the poll up. You'll be asked to pick which one is the melanoma. And I'll get you to, as we go through, I want you to write down with a pen and paper or whatever way you can record it on it, just for your own benefit, which one of 1 to 17 you think is based on the clinical images. So here we go on the clinical, that's 1. If you've got a pen and paper, just write down 1 if you think that's a melanoma, and nothing if you think it's not. It's 2, 3, 4, 5, 6, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So, I think you have two polls here. Thorsten, one for the clinical images. You want to put that one up now?
We'll do the one with.
Now, if the melanoma is going to be one of the even numbers, so we can only put 10 options up. So you've got choice of 2, 4, 6, 8, 10, 12, 14, 16, or none. So make your choice based on what you thought. Now, if you pick one of the odd ones, well, you were wrong anyway. So, sorry, we didn't have 17 options.
Technical limitations. Give it a few more seconds till the majority votes. Come on, vote. Give it your best guess.
So the speed at which that was given to you is similar to real life when you've got a patient with 1,000 lesions. You don't get much more time than that. But you'll see dermatoscopy in a minute. The idea is to see if you improve between the clinical and the dermatoscopy.
Okay, 3.
Dermatoscopy will be easier.
2. Come on. 1. All right, we'll end it. Okay, here we are.
So 14 is the first, and then none, and then 8. Okay, now we go to the dermatoscopy images. Okay, same again. Write down on a bit of paper. One of these is going to be a melanoma. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Okay, so Thorsten will put up the poll again, and you vote again. And again, it'll only be the even ones that you get to vote on.
Let's relaunch the poll. Okay.
Okay, well, you can see there that the dermatoscopy made a huge difference. And number 8 was correct. And you can see here, the 2 that I pulled out to look at were 2 and 8. These both got excised. And number 2 because of the peripheral clogs. Okay, it was benign. Number 8 was an invasive melanoma. You can see here, that's what it looked like. It looked like a nevus, and some of you picked it because you're very, very good. But this is an example where it's even in the line of the ribs, the line you expect a nevus to be in. But when you look at this, it's a disorganized lesion. It's got chaos, it's got white lines, it's got all sorts of stuff. By the way, blue lines have the same significance as white lines. Okay, blue lines have the same. but they indicate that it's invasive. It was, Breslow, I think it was 0.6 of a millimetre. Okay, last case. Now, a tattoo complicates things a little bit, and I'm going to show you 6 lesions. And at the end of the 6, you will get a chance to pick 1 to 6 which one you think is the melanoma. So, pretty straightforward. Number 1, just write down on a bit of paper which one you think is. It's up beside the left ear. Number 2, beside the left cheek. Number 3, out to the right. Number 4, within the tattoo. This is real life. You've got to sort these things out, don't you? Number 5, within the tattoo. Number 6, right between the eyes. I think it's enough time, Thorsten. You can pull up the poll.
So obviously, we have 6 options.
Unfortunately, I told the answer at the bottom. That's all right.
People are certainly paying attention to it. You can see the numbers going the right way. That's a good test. All right, let's 3, 2, 1. All right, stop. Here we are.
Fantastic. Fantastic. Okay, well, anyone interested to see what happened when we cut that out to the tattoo? There it is, right? Square between the eyes. Now, how good is that? That's real hunting, right? That's a lethal shot right between the eyes. That's what it looked like when Charles Elliott, who worked with me, cuts my lesions out, did a beautiful job keeping the tattoo symmetrical, and the eyes are just moved very close together. So thank you very much. And that link at the bottom, www.skincancermasters.com, that's where you go to get information about the Master of Medicine course at the University of Queensland. And that is the ultimate qualification in skin cancer, diagnostics and management. And Tony Dicker, who's here tonight, he's one of the course coordinators as well. We both highly recommend that particular course for those who just want to take it to another level. I'll stop sharing now, Thorsten.
Okay. Thank you, Cliff. Amazing talk. It's very educational, and you made it very simple. So we don't have actually too many questions. This is very clear and concise. So let's start with, we have a question, does a melanoma or can a melanoma mimic an SK?
Certainly, a melanoma can mimic a seborrheic keratosis. Although the melanoma is melanocytic and the SEB-K is keratinocytic, but in Australia, for example, that patient with multiple lesions, the man on the right, most of his lesions were seborrheic keratosis or solid lentiginous. And in Australia, about a third of the things we cut out mistaking for melanomas are actually solid lentiginous, lichen-planus-like keratosis or seborrheic keratosis. So they can. And the reason is that seborrheic keratosis and solid lentiginous have an abrupt border. And that may, in some cases, be not abrupt on all parts. And so they're more likely to have an irregular border than a nevus is. And often if they have regression, they have some grey colour. The other thing is, because seborrheic keratosis and solid lentiginous are very common, melanomas can nestle within them, between them, and actually collide with them. And so the answer is yes, they can be mistaken, and more so in places with extreme UV exposure like Australia and New Zealand.
Okay, perfect. And then we have a question regarding young adults. So when you consult them, they have no history of melanoma, they have type 3 skin. How often do you recommend they have a skin check?
Yeah, that's a good question. We base the frequency of skin checks in Australasia on the risk. So a high-risk patient with a relative risk of 5 or more, we recommend 6 monthly skin examinations. That means a patient with previous history of melanoma, relative risk of 10. Patient with more than 100 nevi, relative risk of 7. And other patients, for example, who've had BCCs, solar keratoses, have a relative risk of 4. We recommend 4 monthly examinations. People who are low risk, we don't recommend regular skin checks. So if someone has no risk factors, no family history, and no concerns, we say come and see us if you have a lesion you're concerned about. It's officially we're told not to screen people who are low risk, but we opportunistically examine people. For example, if someone comes in to a GP with a respiratory condition, well, they'll get their chest looked at while that's being examined. We like to learn to recognise things. And in Australia, because there's a high risk of people having a history of sunburn, having relatives with melanomas, it's quite common for general population people in the mature age to come in once a year for skin check. We certainly don't stop them doing that, but we are not encouraged to recommend that.
And there's a question that fits right in. When they do a skin check, how much time do you allocate for a full body skin exam, skin check?
Yeah, so that varies with the patient. In my own practice, a patient attending for the first time, we allocate half an hour, 30 minutes. And routinely for review skin checks, 15 minutes. But quite a few patients, we say, allocate half an hour for their follow-up skin check, depending on the number of lesions they have that we need to examine. And sometimes I have patients who attend for 45, an hour. You know, it depends on the patient, but never less than 15 minutes for me, and never less than half an hour for the first time they attend.
Okay. And then we have a question regarding non-white patients. Do you have any experience with your algorithm or the algorithms working for
Certainly.
color?
Certainly. Now, people with type 5 and 6 skin don't require regular skin checks. They are advised to come and see us if they have something they're concerned about. So we don't examine them routinely. They have the same incidence of melanomas of the nail matrix, melanomas of the palms and the soles, and mucosal melanomas, the same instance as people with type 1 to 4 skin, but they don't get the other melanomas, or they get them very, very rarely. So proportionally, they mainly get nail matrix, acral melanomas, and mucosal melanomas, but they don't get them any more than anybody else does. So as far as the dermatoscopic features, there's no difference. What I advise in my book, what I advise teaching is that you always look at normal skin with your dermatoscope on every patient, as well as looking at lesions to establish your threshold for that patient. For example, on normal skin with people with type 5 skin, you'll often see grey circles on normal skin. You don't cut their skin out just because there's grey circles there, because for them that's normal. So it's very important to always examine normal skin, to set your calibration before you actually examine lesions.
Okay, and on the topic of skin of color, there's a question regarding color within a lesion. What do you consider? You spoke about chaos of color, I guess, and is there a minimum area you would consider to make a lesion chaotic?
Yeah, well, with pattern, we say the pattern must be large enough to form a pattern. So we say around about 20% or more. If you've got a little bit that is a structureless, which is 2% or 3%, that's not affecting the pattern. If you've got a little bit of obstructions, that's 5%, it's not affecting the pattern, but if you've got a little bit of obstructions, that's 30%, it is. So about 20% is the cutoff for pattern. The colour, there's no cutoff. So if you've got a black dot at one end, that's the chaos of colour. Like it's a significant black area at one end, that's the chaos of colour. Chaos of border abruptness again, we're talking about biologic symmetry. So, and pattern chaos is something you assess from a distance. Now, everybody's going to have different thresholds, but I explain it like this. When you're assessing for chaos or for pattern, you take your glass off, rub your eyes, make them all foggy, and that's when you assess pattern. But when you're looking for clues, that's when you look with magnification and look very, very close. If we follow a system with revised pattern analysis, with objective terminology, if we follow a system and we follow it right through, you might see different patterns to me, but we'll end up with the same conclusion at the end. Okay, because it allows for that. With respect to pattern, if in doubt, call it chaotic. But with practice, when you look at hundreds of thousands of lesions, deliberately benign lesions, you will soon become very expert and consistent at assessing things that are benign. And you'll be able to judge biologic symmetry because you get the feedback from the things you cut out that were benign to help recalibrate your assessment. Look at lots of lesions. That's the main advice I've got.
Okay, and I'm sure you've seen, talking about lots of lesions, you've seen lots of lesions in elderly people. And how do you differentiate regression in those patients due to aging, I guess, versus regression in a melanoma?
Look, regression, you don't see regression through a dermatoscope. You see it through a microscope. What you see through a dermatoscope is things like grey colour or white colour from collagen being laid down from scarring. But I don't see regression. I leave it to pathologists. I keep it objective, and I'll describe grey and I'll allocate significance to grey if it's asymmetrical, or if it's on the face, even if it's symmetrical. And if I can't call the lesion one of the 5 common benign things that's got grey on the face, I'll cut it out. The pathologist will tell me if it's due to regression.
Okay. Then we have I guess what someone referred to as the underwear footprint. How do you handle examination of that area? And do you encourage self-examination? And then there's a related question: how do you examine mucosal surfaces or possible melanoma?
Okay. Well, I suggest that you look at that link I gave you for the skin check examination, because that covers all of that. Okay. But basically, I start my examination looking in the mouth and the eyes. That's where I start. Okay. I let the patients leave their underwear on, but I retract the bra and inspect the breasts and inspect everything under without taking the bra off. I just retract it. And I retract the undies down over the pubic area and the buttocks. I don't look at the genitalia. I don't look at the vulva. I tell them to self-inspect. I always ask, and I actually make notes about, ask them if they've got anything in the genital area that they're concerned about or that's changed. And if they ask me to look, then I look. I don't routinely look there. I ask about it first. But I do tell them when they have their pap smear or their gynecological examination to make sure they ask the doctor to check for that sort of thing, any things or pigmented things or whatever that shouldn't be there. But I do look at the breasts, I do look at the buttocks. Okay,
and then there's an interesting question regarding colposcopic procedures, whether you see an application that's tailored for dermoscopy, examine
no.
ball region.
No, I don't do any colposcopy, and I don't do, like if a patient says they've got something in their vagina and I want to look at it, I'll look at it for sure. But no, I don't routinely examine.
Okay. Then we have a question regarding treatment. Is it Efudex or Aldara? Do you use those on tattoo areas?
On what areas?
Tattoos.
No. If I'm using Aldara or Epidix, it makes no difference whether it's a tattoo. It has no impact on my decision. For example, if someone requires Epidix treatment to their forearms, for multiple solar keratoses, the presence or not of tattoos is irrelevant.
Okay.
Yeah.
Okay, and then maybe the last question is regarding, well, there's a couple related. What kind of lighting do you have in your office? People want to know.
Certainly, I've got fluorescent lighting. I've got double fluoros over the couch, and I use my dermatoscope as my light source.
And do you, for digital imaging, what do you record?
I use a photo finder system at the moment. Prior to that, I used cameras, big heavy cameras with dermatoscopes attached, and I had multiple cameras. One with I had a derm photo and a fluid, a DermLite fluid. That's one of the old, if they make them anymore, the non-polarized DermLite fluid. That was a beautiful camera for a dermatoscope for taking images, and many of the images in my book were the DermLite fluid and the DL3 attached to a Canon. Great for polarized and non-polarized images. So I found the DermLites particularly good for photography because they have a light and attached to a camera well. But now photo finder system, I find it very convenient, and it's just an expensive system, but it doesn't matter what system you use as long as you have good sharp images and you have some way of storing and retrieving. Doesn't matter what method you use at all.
Okay, excellent. Let's wrap this up. I actually have one poll myself. We're interested in terms of technology, what everyone is using, what kind of device they're using right now to watch this Zoom episode. So I'm just going to launch this. You'd really do us a favor if you could just answer that, and that'll help us plan for future episodes. So I'm suspecting there's a high number of people on smartphones, but we'll see. Okay, perfect. I'm just going to share that with you also, just so you you know what. Not that you that it matters too much to everyone, but thank you so much for that. Anyway, so thank you, Cliff. This wraps up today's episode of On the Spot. This was number 10. In case you missed parts of it, you'll get an email about 24 hours from now with a link to the recording of today's episode. I hope you enjoyed it. I think we did. I hope, Cliff, you did as well.
I certainly did, and thank you very much for the invitation, and thank you for everybody for turning up. Fantastic.
Yes, we received lots of comments in the chat, and we're very grateful for those. We love having you. We love having a large crowd. I think in this day and age, this is very important, and we love doing this. And this is, as I said in the beginning, this is one great way for us to make sure we continue our mission to support dermoscopy education worldwide. If you want to make sure you don't miss a future invitation on the subject of inviting us to the next episode, jump on our website. There's a link to our newsletter. Just fill that out. You won't be spammed, but at least you'll get a notification ahead of time. Next episode will be scheduled. You can also just follow us on Facebook or Instagram, which is where we'll post announcements. And as always, after you leave today's episode, you'll have a chance to leave some feedback. Cliff and I will really appreciate that. So if you could leave some comments, ideas, thoughts we can use for future episodes, things we can improve on, that would be much appreciated. This time you'll also have a chance, if you are interested in maybe obtaining a new DermLite or some other equipment from us, you'll have a chance to leave your name and number and email, and we'll get back to you, or we'll forward it to the right person who can reach out to you. So anyway, for Cliff and the entire 3Gen team, I thank you so much for being here. making the time for us. And depending on where you are, have a great morning, have a great day, have a great evening. And for everyone and every one of us and Cliff, have a wonderful weekend. Stay safe and see you next time.